Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/DMZ. This program has been supported by an independent educational grant from Gilead Sciences Incorporated.
Welcome, and thank you for joining this educational program, From Guidelines to Ground Truth, the Reality of Rapid Art in the Real World. I'm Dr. David Wohl. I'm a professor of medicine in the Division of Infectious Diseases at the University of North Carolina, Chapel Hill. And I'm happy and pleased to be joined today by Dr. Professor Antonella Castagna from Milan. Dr. Castagna, can you introduce yourself, please?
Yes, I'm Professor Antonella Castagna from Vita Salute San Raffaele University and from San Raffaele Scientific Institute in Milan, Italy.
Wonderful. Thank you. In this activity, together, we'll discuss how rapid ART is implemented in the real world and how to more effectively apply the supporting evidence to clinical practice. So, why does this matter? Well, there's quite a considerable amount of evidence about the benefits of rapid ART. But as we'll discuss over the next few minutes, there is this gap between the evidence base that we have and clinical practice. So again, there are supportive evidence, including observational studies, as well as even clinical trials that indicate that rapid ART initiation has benefits. And we'll talk about those. In fact, major guidelines recommend starting HIV therapy as early as possible based upon these data. But again, implementation remains very variable and mixed across different settings and for a whole bunch of different reasons that we'll try to explore. And again, we understand that the barriers are on multiple levels. All right. So they could be structural, they could be operational, and they're not conceptually based, meaning it's not that we don't think that starting HIV therapy early is a bad idea. We recognize, most of us, all of us, consensus-wise, that this is a good idea, but there are barriers that are obstacles to implementation the way that we'd ideally like. So in this activity, we'll kick the can on some of those concepts. We'll reevaluate the evidence for rapid ART, so we're starting on the same, starting point, and then explore some of those barriers that I mentioned to implementation. And then together, we'll be able to discuss, really from two very different perspectives, but I think complementary, practical strategies to improve delivery of HIV care as soon as possible after the diagnosis. Let's start first with the evidence behind rapid ART. And to do that, I think it's important just to take a step back and think about, well, what do we mean by rapid ART? For some folks, it could mean at the handshake. And by that, I mean the same day that someone is diagnosed with HIV, they start on HIV therapy. And again, that's an ideal, but practically speaking, extremely difficult. So rapid may mean different things in different settings to different people based upon what is possible. So it may be same day where that is feasible. It may be within the first 3 days or within the first 7 days. But the key principle we're talking about here is not to do what we did historically in the past and wait, or put in lapses in time before we would start HIV therapy that we could control, right? So we would sometimes do that. So again, there's a spectrum of ART initiation from diagnosis to same day to within hours to days to within a week to this weeks later, which I think we can agree is no longer optimal in most every situation, with some exceptions. Dr. Castagna, your concepts about the same thing. I know you've thought a lot about what rapid means in your setting. Your thoughts about what is rapid ART?
Yeah, I would say that in real world clinical practice, the concept of rapid ART should be more flexible than the rigid definition. We know that often we aim for having the same day initiation, but particularly when the patient is stable, is a readiness for be treated. But the concept to me is to avoid unnecessary delay in initiating ART. I think that this may be the balance between guidelines, evidence from clinical trials, and clinical practice to avoid unnecessary delay.
Great. So you and I both agree that we should not delay HIV therapy. In the olden days, we did. We wanted to prove that people were ready to start, that they were committed. We'd make them jump through some hoops, if you will, come back in 2 weeks, start your prophylaxis first, and let's make sure you take your But we realized that that really did not work for a lot of people, and we lost people. So guidelines have reflected this evidence, whether we're talking about the WHO guidelines or EACS in Europe, the Department of Health and Human Services in the US, and in Britain, the BIVA. They all recognize that there is psychological benefits probably in signaling the urgency of starting HIV therapy early that can lead to benefits. And then the data that we'll talk about in a second that show that after diagnosis, as soon as possible, starting HIV therapy actually has benefits vis-a-vis outcomes we care about, including time to viral suppression and even retention in care. And those are really important signals that, again, I think endorse this practice that we're so wrapped up into of trying to achieve rapid ART. And what is this evidence base that we keep talking about? Again, there's a lot of different data points that we could look at. And there are clinical trials that have been done now, largely in resource limited settings where there may be more feasibility, but also greater benefits to starting HIV therapy early, especially in places where TB is endemic and is really a major threat to people living with HIV, and time is of the essence in getting their immune system stronger. But we do see that there's improvement in viral suppression, retention and care, and linkage to care that pervades different types of studies in different geographies. In fact, Cochrane did a systematic review, a meta-analysis of standard ART initiation versus rapid, and again, found benefits in these same sort of categories. Implementation studies, also important, a lot coming from San Francisco, where again, there's some benefits in their clinics where they are able to have ART available to people. Again, I think really the dots connect to benefits on multiple levels, including personal and public health, for starting ART earlier. And again, Dr. Castagna, in your setting as well, I don't think you find that this is any different. And again, we have different sorts of populations. You may have more people who are migrant. You may have more people with advanced disease. So how does this square with what you're doing there in Milan?
I would say that these key findings are consistent with what we observe in clinical practice. Then you have to contextualize the context because it depends where you work, it depends the facility you have. But I think that the most important concept to me, to my experience, is to outline that the early ART initiation is able to reduce time for virus suppression. I think that this is the most important finding, at least in our experience. Then we can have a benefit in retention in care, in linkage to care. But for me, the most important one is to shorten the time to virological suppression because the benefit is for the individual and for the community.
Absolutely. Again, and that's great. And again, we could talk about there can be exceptions, right? There's exceptions to every rule where it may be really smart to wait a little bit, but we don't wait just for the purposes of waiting, right? Benefits of starting outweigh the risks. Let's do a question. So please answer this challenge question. So why aren't we doing this more readily? We all agree this is a good thing to do. The studies, prove that this is a beneficial thing with better outcomes. Well, again, as Dr. Castagna mentioned, context is everything. So a lot of the trials, the trials that we have, were done in settings that I think are a little bit different than what we have here in North Carolina or what we see in Northern Italy. So the populations are different. Like I mentioned, OI stress is different. And again, our operations may not support this. At our particular institution, we don't have a closet with, HIV sample and HIV antiretroviral samples just ready to give out and take out of the box. There's a process. There's insurance issues and things like that in many of the places we work. So the studies that were done may not be completely representative of the realities of our clinical practice. On the other hand, again, in our clinical practice, we would love to do some of this, but we just don't have the infrastructure. Or we could do this, but not in exactly the same way, where for me, rapid ART may be within 7 days rather than within 7 hours or even 72 hours. Again, there's this disconnect, I think, a little bit between what we see in some of the studies and our clinical practices that we need to try to bridge. So this leads us to our second question. So please answer this challenge question at this point. So again, we understand that there are data and there's reality of how to implement the data. And that opens up, a wonderful world of implementation science of how do we take what we know and apply it in clinical practice. And I think many of us are doing this. And I know that even in clinics that struggle, the time from initiation to initiation of HIV therapy, from diagnosis to coming into clinic, this is shortened over time. We know that, even in the places that have the greatest stresses. So again, I think we're moving the needle, but clearly there are some obstacles. And in the next section, we'll talk more about how to really align the data and the evidence with strategies for implementation in real world practice. So thank you again, Dr. Castagna, for talking about this with
David.
me. We'll move on to the next section.
So, for second presentation, we would like to focus on aligning rapid art expectation with the real world outcomes. We know that there are barriers to promote early rapid art, but we know the benefit. Benefit is faster viral suppression, higher linkage to care, improved retention in care, earlier reduction in transmission risk, and we can have barriers. Barriers like longer time to viral suppression, higher loss to follow up before treatment initiation, lower linkage and retention to care, and delayed prevention benefit. So if we agree on the principle, why the uptake is still inconsistent, perhaps we could have many factors. I would ask David, which of the barriers do you see most commonly in your setting?
Yeah, no, you're exactly right. We do agree on the principle, but we definitely have some variability in our capability to give people ART therapy and get them access to it as early as we would like. I think one thing we should recognize is some of this is in our control and some of it isn't. So the things we could control, we should control. That's just good advice for life in general. So we don't really need to wait for laboratories anymore, right? For instance, we don't need to prove to ourselves that someone's going to come back or take their medicines, because we find that leads to delays that aren't beneficial. So I think we should give people the benefit of the doubt. It sends a signal that this is urgent. You need to take your medicine. You need to be engaged in care. And psychologically, that seems to have benefits. For us, it really comes down to money. It comes down to who's going to pay for what, how they're going to pay for it, and getting that all arranged. So in our clinic, where we don't have stock rooms full of medicines in the back, we really do have to go through processes. And I know every place is different, every system's different, but for us, going through that. But even with that, most of our folks can get their medicine, I would say, within 3 to 5 days, which to me is pretty rapid.
Okay. So as you said very correctly, David, the barriers are real and they can differ by setting. So to me, the most important message is to face parallelly the barriers without avoiding to initiating art. Barriers can be related to the clinic, such as staffing, workflow, intake process, may be related to the pharmacy, one site versus mail order, may be related to the payer of the policy, like prior authorization or coverage restriction, may be related to supply, drug availability or stop distribution, and may be also related to the possibility to follow up the patient. So I would say that, as I said before, the important message to me is to initiate early the art, facing the barrier in parallel. I would say sometimes is the readiness of the patient that can be a barrier for early art initiation, but we can try to favor the readiness of the patient without delaying the art initiation. About the patient, we know that the patient level consideration is important. Patient cannot be ready for antiretroviral initiation, and we have to promote this readiness. Patient may have mental health or social context, stigma, disclosure, problems in follow-up support, or competing priorities. Sometimes the housing, the access, the instability may be problems for the patients, but the patient factor should inform the care, not default to delay. We have common drivers of delay and labs, pharmacy, patient factors, system constraint. You see here a long list of system barriers and a long list of patient readiness. I will ask to ask you, David, how do you typically approach starting heart when some of the barriers are present in your clinical practice?
Yeah, absolutely. I think over the last few years, we've recognized the urgency of starting HIV therapy as early as possible. And it's actually interesting because, when it comes to acute HIV, we get this message right away, right? Because time is latency. We feel it's almost an emergency. So that kind of gave us a little bit of an experience with really mobilizing to get HIV therapy as soon as possible. And we've been doing that for years because of our acute HIV program. That's translated really nicely into people who come in without acute HIV, but do need to start. So, again, having everything in place, the social workers who understand how to apply for patient assistance, right? Making sure that we know exactly what people's insurance is, applying for insurance when we need to, really getting through sort of the exercise of navigating the barriers so that we can get people therapy as soon as possible. And really brainstorming in issues when there's problems. I do think there are some situations like when there's an acute OI, like an opportunistic infection, that might delay things, or when people are unstably housed and we really are unclear where to send the medicine, because a lot of HIV therapy and prescriptions in the United States are mail order. People are sent, their medicines by mail, believe it or not. So that could be hard if someone doesn't have an address. So that makes it harder. And I do think there are circumstances where you do have to step back and make sure that everything is all aligned. But in general, we mobilize a multidisciplinary team between the provider, social work, nursing, to make sure, and financial counselors, to really make sure that everything is set up so that we can get people medication literally within 3 to 5 days.
Thank you, David. Thank you for your comments. I totally agree. I think that we need to promote early art initiation facing the possible barrier we have. And now, please answer this challenge question. So, key takeaways. Rapid art in the context. I would say that rapid art is widely supported with initiation as early as possible recommended across guidelines. In practice, time of initiation is often influenced by the system, by other factors that we need to face in a prompt way. While most patients can start early, there are some situations in which a brief delay may be appropriated in selected clinical scenario. For instance, opportunistic infection, some opportunistic infection like cryptococcal meningitis or TB. So we need to look at that. patient readiness, very important, but it's also very important to promote patient readiness in order to have a early ART initiation. In many settings, ART initiation occurs while clinical, patient, and system factors are addressed in parallel, as you say before, David, in a multidisciplinary assess. And now, please answer this challenge question. So, Dr. Wool, I would like to thank you for this great discussion and thank you to our audience for watching.
This has been an activity published by PeerVoice.